Okay. Good evening to everyone, and hope you must be having nice, extraordinary lectures from everyone, from all the KMC faculty, alumni faculties, and it's my privilege to be part of this group and involved in this teaching activity. So today I will be dealing with salivary gland neoplasms. Okay. So even though for you guys at this level, I think in pathology as such, salivary gland tumors, as such, if you see, you need to know mainly about pleomorphic adenoma and Warthin tumors. These are the two main tumors. You must be knowing it out. You may get short notes or something like that. But mainly, I thought like maybe since it is a single lecture, I thought of like at least covering reasonably good area so that you will get some good exposure about the salivary gland neoplasms. Because clinical point of view, this is very important when you go to final year or even the clinical rounds and all. These are the very common tumors you will get to see. So that's why I thought like maybe I'll cover not very extensive, but at least a few of the entities which you should be knowing. Okay, so I'll just get into that. Basically, the salivary glands as such, they are these tumors of salivary gland. They are basically heterogeneous group. So they each of them are like a different type, and even inside the type itself, right, you have like morphology varies a lot. So that's why they are called as like heterogeneous group of tumors. So they have great diversity of morphological features, and even though they are relatively uncommon than the other tumors what we regularly see, this majority of the neoplasms, they are benign. 80% of them are benign. Only 20% are malignant. So various types of salivary gland tumors are best plays a role because all the tumors like look alike. Diagnosis. Okay, so even the all head and neck neoplasms. So the originate in the and other sublingual glands, it is almost like less than 1% involvement. But whichever if it is involved, most of them are going to in the minor glands. Benign tumors accounts for 63 to 78%, and the most common benign tumor is pleomorphic adenoma that you need to be knowing in and out. And also like Warthin tumors comes around 6 to 14%, and most common malignancy is mucophthalmic carcinoma. So the most common minor salivary gland tumor involvement is mostly in the palate. Okay, that is the most common minor salivary gland tumor involving site. 42 to almost 54% are involved in the palate. The proportion of malignant tumors varies significantly by site and is the greatest in the sublingual glands, tongue, floor of mouth, and retromolar areas. And the most common tumor among the children is mucoepidermoid carcinoma. Okay, so even though like the salivary gland tumors commonly involves the adults, especially around it is 5th to 6th decades. Okay, that is the most common age group involved, the salivary gland tumors involved. And it has a female, very clear-cut female preponderance is there, and except like Warthin tumor where it is more common in the male. So 5% tumor occur in children younger than 16 years of age. The benign tumors most often appear in the 5th to 7th decades. Malignant ones tend on average appear to somewhat later age group. And the neoplasms in the parotid glands produce distinctive swellings in front of and below the ear. So in general, when they are first diagnosed, both benign and malignant lesions, they range from 4 to 6 centimeter in diameter. So ultimately, there are no reliable criteria to differentiate on clinical grounds. So the morphological evaluation becomes the very vital in this salivary gland neoplasms. So something to remember, this is called the rule of 80s, and you can just, it is approximate value only, but it almost fitting into that in this criteria. Like 80% of the parotid tumors are benign, 80% of the parotid tumors are pleomorphic adenomas, 80% of salivary gland pleomorphic adenomas occur in the parotid gland, and 80% of parotid pleomorphic adenomas occur in the superficial lobe, and 80% of untreated pleomorphic adenomas may remain benign. Only the 20% has the chance to transform into malignant one. Okay, just remember this rule of 80s. And the etiology, if you take the usual that viral EBV, CME, they all involved in this neoplastic process, ionizing radiation and occupational hazards like asbestosis and all those things also, nickel and silica dust, they all involved in the precursor reagents actually. So the employment, the woodworking area, rubber industry, beauty salons, they all have the vulnerability. And also like lifestyle, like Warthin's tumor shows a strong association with cigarette smoking, and also some of the endogenous hormones also involved in this etiology of salivary gland neoplasm. So cell of origin as such, if you take any tumor, if you take, we should know the cell of origin. If you know the cell of origin, then you can make out what this, what is the tumor, the overall the behavior and the composition of the tumor, and what is the genetic composition. All you can come to know when you know the cell of origin. So any tumor, if you take any lymphoma or any other tumor, if you take, you need to know the cell of origin. So by definition, cell of origin for a neoplasm rather than the developmental process underlying the tumor. The formation or development of tissue from the undifferentiated sets of the germ layers of the embryo. Okay. So there are so many theories involved in salivary gland neoplasms, basal cell theory, pluripotent, semi-pluripotent, bicellular reserve cell theory, multicellular. These are all not important for you. I'm just for the sake of completion, I'm saying all these things. Okay, basically you need to know what are the tumors arising from the excretory duct, what are the tumors arising from the intercalated duct. Because if the tumor arising from excretory duct, they will have some peculiar characteristics. If the tumor arising from intercalated duct, they will have some kind of peculiar character. That's the reason you need to know the cell of origin. So, for example, excretory duct, you have mucoepidermal carcinoma, primary squamous cell carcinoma, salivary duct carcinoma. And from the intercalated duct, you have pleomorphic and monomorphic adenoma, polymorphous low-grade adenocarcinoma. Like that, you have acinic and adenocystic carcinomas. So these are all out of your scope, but still, I just want to show this. Like you need to know, like neoplasms composed of luminal and modified myopithelial cells, and neoplasm composed of primarily of myopithelial cell, neoplasm composed of primary of luminal and acinar cells. So like that. So if you see the pleomorphic adenoma, that comes under this neoplasm composed of luminal and modified myopithelial cells. Okay. So the genetics, there are many genetic basis there for all these tumors. There have been extensive study and research is been done in the recent classification released by the WHO. You have all these genetics of the salivary gland tumors. Okay, so for example, you have like MAML2 for mucoepidermoid and Warthin's tumor, and c-KIT and c-KIT mutation for the adenoid cystic carcinoma. So like that, you have so many tumors with underlying these genetic mutations. Okay. So basically, what you need to know is, this is the thing you need to know. This is just like compressed classification of salivary gland neoplasms. If you really see the real classification of the salivary gland neoplasm, that's very extensive. Involves so many other subgroups are there, so many subtypes are there. But anyway, you need to just know this one. What are the benign tumors? What are the common malignant tumors? Under the benign tumor, you have pleomorphic adenoma, Warthin tumor, oncocytoma, and other adenomas like basal cell adenoma, canalicular adenoma, ductal papillomas. And under the malignant tumors, you have mucoepidermoid carcinoma, adenocarcinoma, acinic cell carcinoma, adenoid cystic carcinoma, malignant mixed tumor, and squamous cell carcinoma, and other carcinomas, rare carcinomas also there. Okay, this is the reasonable classification of the salivary gland neoplasm. So just for your level, you need to know this at least. Coming to pleomorphic adenoma, otherwise it is known as mixed tumor. Okay, you need to know this. Sometimes the question paper, they may not ask directly as pleomorphic adenoma. They'll simply ask benign mixed tumor of salivary gland. So you should not be wondering what it could be and what tumor. I never studied this. Okay, you need to know that pleomorphic adenoma is otherwise known as benign mixed tumor. Okay, so it was suggested by Willis, and it is the most common neoplasm salivary gland tumor, and the basically it is a benign neoplasm. Okay, it composed of epithelial cells, mesenchymal cells, and under the mesenchymal you have like chondroid, myxoid, and osseous. So all those cells can be seen in this tumor. Okay, other names are there, and it's not really needed for you. You may not get all these names. These are very outdated names. And the salivary gland tumor, basically this originates from the epithelial component of the salivary gland. Okay, so these are the chromosome 12q13 and 15, and other abnormality like putative pleomorphic adenoma gene. This is called PLAG1, putative pleomorphic adenoma gene. Okay, it has been mapped in chromosome 8. Okay, these are the two main genetic abnormality you usually find found in the salivary gland pleomorphic adenoma. So this is the most common tumor, as I already told, and it is a if you below the up to the angle of the mandible, and here also this is the tumors involving the submandibular gland. Okay, it's a lobulated. Okay, can you make out the lobulation? You can see this kind of lobulations here. Okay, this is the intraoral location in the palate. You can see, and you can even see the bluish tinge. That is because of the cartilage formation, the chondroid areas that can give this kind of bluish tinge. Okay. And grossly you can make out this circumscribed tumor with sometimes you can even make out some cartilaginous areas in the gross itself. Okay, cut surface is some kind of gray to brown areas you can make out. Okay. So the hallmark is the morphologic diversity. That is the reason it is known as pleomorphic adenoma. Pleomorphic means that the pleomorphism in the morphology. Okay, they are variable, diverse, structural, and histological patterns. It demonstrates glandular epithelium and mesenchyme-like tissue, and the proportion of each component varies widely. Okay, they are well circumscribed, encapsulated tumors, and you can they are categorized into they categorize pleomorphic adenoma into 4 categories, like primarily myxoid and myxoid with cellular component, and predominantly cellular and extremely cellular, like that. The extremely cellular one, you may not see the other components like the chondroid and the osseous areas will be very less. And myoclone cells are the major component of pleomorphic adenoma. Even if you do FNAC, these are the cells will give a clue that you are dealing with pleomorphic adenoma, along with the chondromyxoid areas. Okay, they have a variable morphology as I already told, and yeah, this is the picture actually. You can even use this picture to draw it in your exams actually. Recently, I corrected the MBBS paper, the previous batch. I have seen like some of the people have drawn the pictures actually. Whenever any question is asked, whether the papillary thyroid carcinoma or Hodgkin lymphoma or this kind of glioma, anything, they give this kind of like they draw a very nice picture like this and they label it nicely. See, even if you do a picture like this and if you put the proper labelings, if we see this, we won't even read the text part actually. We'll give full mark if you put up a picture like this and nicely label them like in appropriate manner, not like randomly or something. But if you really understand the tumor, you will know what are the things you need to label and all. So try to make these kind of pictures in your exams. Okay, don't spend too much time, but practice it so that you can do it in a quicker manner. Okay, So this is the chondroid area. You can see here bluish area with the chondrocytes, and this is the connective tissue stroma. This is the myxoid areas stroma, and here you can see the ductal and the myoepithelial cells proliferate sheets. Okay, and here also you can see the ductal, the tubular structures, and sometimes you may have this kind of osseous areas as well. Okay, this is a picture of pleomorphic adenoma. These are the histological pictures, and that was the schematic diagram. This is the real pictures, and where you can make out this cartilage and these myoepithelial cells in the background, and studded into the fibromyx, the chondromyxoid stroma, and some tubular structures also you can make out. Okay, these are the myoepithelial cells in a closer view. Myoepithelial cells almost looks like a plasma cell. Okay, eccentrically placed nuclei with abundant eosinophilic cytoplasm. Okay, these are the myoepithelial cells. Okay, you have the stroma, myxomatous stroma here, and you have this kind of chondroid material here, and along with ductal epithelials and myoepithelial cells. Okay, so this is a typical picture of pleomorphic adenoma. The differential diagnosis comes here: polymorphous low-grade adenocarcinoma because of the low-grade quality of the tumor, and it will mimic like the pleomorphic now. But still, like if you see the other typical features of that myoepithelial cells and chondromyxoid areas, you can exclude this polymorphic low-grade adenocarcinoma, which will have a invasive areas, and it won't be circumscribed lesion. Adrenal cystic carcinoma is also same. Grossly, they may look same, but you may have invasive borders, and yeah, the appearance will be like very cribriform. And epithelial myoepithelial carcinoma and squamous cell carcinoma, mesothelial carcinoma, all these carcinomas will have a high degree of atypia. Okay, the treatment-wise surgical excision is recommended, and superficial parodontectomy with preservation of the facial nerve is recommended one. Okay, so just an enucleation will not suffice for this tumor because the recurrence rate is very high. So the total removal of the tumor is recommended. And also, like just to know what are the tumors which can have myoepithelial cell participation, like pleomorphic adenoma, myoepithelioma, basal cell adenoma, all these will have predominantly this myoepithelial cell component. And malignant tumors like adrenal cystic carcinoma, polymorphous low-grade adenocarcinoma, epithelial myoepithelial carcinoma, myoepithelial carcinoma, and carcinoma ex pleomorphic adenoma. Carcinoma ex pleomorphic adenoma is the one where you already the patient had a pleomorphic adenoma, and you remove the tumor, or you didn't treat the tumor, remove the tumor, and that becomes transformed into malignancy. When you take out the tumor, you may see the pleomorphic area, the classical pleomorphic areas you will see, along with this the carcinoma areas also will be seen. That is called carcinoma ex pleomorphic adenoma. Coming to oncocytoma, this is another tumor. It's a very benign tumor, circumscribed tumor, which will be composed of mainly the oncocytes in the tumor, and they will have oncocyte means it's typically described as cell with abundant granular eosinophilic cytoplasm. Okay, so these oncocytes, the counterparts can be seen in other glands like thyroid, parathyroid, and kidney as well. Okay. So clinically, they are occur in the older patients, 50 to 80 years, and there is a female preponderance, and the minor salivary glands are very rarely involved in this. Parotid is the most common one. Okay. So typically the tumor is slow growing one, and it will present as a painless mass. Okay, rarely it exceeds 4 centimeter, and bilaterality is also quite common. And if you see the cut section of the tumor, it will have this kind of brownish appearance. Some of the oncocytomas in kidney and they will have that mahogany, that they will call the mahogany brown. That color will be the typical for these oncocytic tumors. Okay, and microscopically they will have a circumscription, and they will have sheets of polyhedral, these oncocytes with abundant granular eosinophilic cytoplasm. Okay, they can be arranged in sheets, nests, and cards. Okay, and if you see the cytoplasm, they will have a typical that the granularity will be there. That abundant cytoplasm is because of the overabundance of mitochondria. Okay, that is the reason we have the abundant cytoplasm. Even the Hurtl cells are oncocytic cells in the kidney and in the thyroid, everywhere. It's because of the abundance of the mitochondria. Okay, you can make out here the cells with a very bland nuclei, the nuclei will not show any atypia. It's a very bland, and cytoplasm will be very characteristically very abundant and reasonably granular. Okay, here this kind of nests and kind of cards also it can come. Okay, differential diagnosis you will have mucoepidermocarcinoma, pneumocardinoma also can come, but you can make out with this. Among them is like acinic cell carcinoma. All can be a differential, but this oncocytic because they all can have an oncocytic metaplasia. So when you doing a smaller biopsy, throughput biopsy, if you are seeing only those area, you may mistake that as an oncocytic neoplasm. When you see the entire tumor, you will have the other areas. Okay, surgical excision is the treatment again. And coming to the Warthin's tumor is the second most common tumor in the salivary gland. Okay, in 1910, the first time it was recognized, and later it was described by Warthin. Okay, 1929. Okay, it occurs exclusively in parotid gland. Okay, there are so many theories involved in this. Anyway, I'm not much going into those things. And smokers, they have almost 8-fold increase in greater risk for Warthin's tumor than the non-smokers. That is the one thing which we need to notice, because when we see a tumor and we know that the person is the elderly patient, the male, and smoker for many years, and you can really make out that this is going to be Warthin's. When you do the FNAC or biopsy, you will get to know that is Warthin's tumor. Okay. This is also slow-growing tumor, painless nodular mass, and firm and in consistency, and it can also have 5 to 14% tumors can have a bilateral presentation. Okay, so there is always you have the lymphoid component will be there, and yeah. So this is the gross picture where you can see these cystic areas here, like cystic areas, and along with this kind of gray white surrounding stroma you have, and the cystic areas will have a very this like can be little shaggy, that cystic wall here. Okay. And the tumor may basically be composed of ductal epithelium as well as a lymphoid stroma. Okay, they exhibit cyst formation, and you have this with projection into the cystic spaces. Okay, and a lymphoid stroma showing the germinal center. Usually they are arranged in 2 layers. Inner luminal layer consists of a tall columnar cells, and which will have the fine granular eosinophilic cytoplasm, oncocytic cells. The outer layer will be the oncocytic triangular, occasionally fusion based red cells. Okay, you may get to see some squamous metaplasia in the lining epithelium, and the lymphoid stroma in the germinal with the germinal center formation will be seen here. Okay, this is a schematic diagram where you can see these oncocytic cells, and there is a low cuboidal epithelial cells here. You have the lymphoid stroma here with germinal center formation. Okay, and this is the cystic space where you will have the eosinophilic, that some debris will be seen here. Okay, murky, some debris material will be there. Okay, this is the histology where you can make out these oncocytic cells with the they are forming the cyst lining. Inside the cyst, you have the eosinophilic, some debris is there, and the stroma has a lymphoid lymphocytic infiltrate. Again, you may have this kind of squamous and metaplasia focally. Okay. So their oncocytic otherwise known as oncocytic papillary cystadenoma, that is a differential diagnosis for Warthin's tumor, and the lymphoepithelial cyst, and its related parotid cyst, and lymphoepithelial sialadenitis, maltomas, all can be a differential in Warthin's tumor. Okay, treatment is definitely the surgical removal. Superficial parotidoectomy is recommended. Okay, so 6 to 12% can recur. Okay, the malignant Warthin's tumor is a very rare condition, very exceedingly rare. I have never seen so far, and yeah, it can also occur. So coming to mucoepidermoid carcinoma, this is the most common malignant salivary gland neoplasm. Okay, this is the second most frequent occurrence of all salivary gland neoplasm, and yeah, 5% of all salivary gland neoplasm is the mucoepidermoid. So under the etiology, you have therapeutic radiation, lipoidal installation, presence of other foreign material, all can cause this tumor. And the cell of origin is cells of salivary gland, excretory and intercalated duct. Okay. So clinically, fifth decade, third to fifth decade can involve females have the more common presentation, and the parotid is the most commonly affected gland, and intraorally palate is the most common site. And the most common salivary gland neoplasm, if you ask, it can come as MCQ also. In children, or which is the most common salivary gland neoplasm is mucoepidermoid carcinoma. Overall, it is pleomorphic adenoma, but if you ask only in children, that is mucoepidermoid. So you can divide this mucoepidermoid into low grade and high grade. Basically, the low grade is a slowly growing tumor, never goes beyond 5 centimeter, and it is not completely encapsulated. Okay, often contains cysts filled with viscoid or mucoid material. Okay, sometimes it is even mistaken as a mucosid. Coming to the high-grade tumor, they grows rapidly, and it can even involve the nerves, especially the facial nerve, which can cause facial nerve paralysis, and even it can have other like ulceration, trismus also they can, dysphagia can have, and it can even metastasis to regional lymph node, lung, bone, and brain and subcutaneous tissue. Okay, that is the difference between low-grade and high-grade. It's important to identify the tumor is low-grade or high-grade because of the prognosis and the overall behavior of the tumor. Okay, so you can make out here blue pigmented mass of the posterior lateral hard palate. You can make out that here, and also here also tongue also has a minor salivary gland tumor, which has this mucoepidermoid carcinoma. Okay, it also has genetic loss of chromosomes 8, 9, 5, 16, Q and 12p. HRAS gene also shown mutation. This tumor. So there is a criteria to follow, like what all according to the histological features, and you give them score, and accordingly the prognosis is predicted. Okay, so grossly you have this tumor with this cystic area. Low grade will have this kind of cystic area with some solid areas, and high grade will have this kind of tumors with invasive borders with a solid cut surface. Okay. So histopathological features, basically they have variety of cell types and growth patterns. Basically you need to identify mucus secreting cells, otherwise known as mucophages, and epidermoid cells like the squamous cells, and the intermediate cells, that is also type of squamous cell only, and the columnar or clear cell. All these type of cells will be seen in mucoepidermoid carcinoma. The name itself shows muco means the mucus secreting cell, epidermoid, mucoepidermoid, and epidermoid and the carcinoma. Epidermoid involves the squamous cells. So they have low grade, intermediate, and high grade. And you have mucous cells they vary in shape, and it will have the cytoplasm stains, positive for mucin stains. And epidermoid cells can be squamous features and polygonal shape. Intermediate cells can be seen larger than the basal cell, but smaller than the squamous cell. That's why they are known as intermediate cells. Okay. Also, you have clear cells. Basically, the histological grades are based on amount of cyst formation, degree of cytoplasmic atypia, and a relative number of mucous, epidermoid, and intermediate cells. For example, more the cystic areas and more the mucus production, that becomes a lower grade, and the more of squamous differentiation and less of this cyst formation and less of the mucophages, then it becomes the high grade. Okay. So already, we saw that. Yeah, you can make out here the low grade where you can see the more cystic areas and a lot of these mucophages, and you can also here also make out the cells with clear cells. Okay, with the mucin inside this lumen here, and here you have the squamous cells. So less of this intermediate squamous cells and more of the cystic area and mucophages, and that gives the low grade carcinoma. Okay, so if you do the mucus stain, mucocarbonate, that will highlight this mucin in the cytoplasm. Okay, here also you can make out all the clear cells having mucin. Okay, so you have this intermediate grade, you have cyst, then still you have the cystic areas with the mucin in the cyst, and you have more of squamous, that intermediate cells here. Okay, so the balance between the cyst and the squamous cell makes the grade, basically. Okay, yeah. So you have the high grade, you have more of these squamous cell areas, but very focally you have this mucus secreting cells. Okay, this is high grade tumor. Differential diagnosis: the new necrotizing metaplasia, phlegm of carcinoma with squamous metaplasia can mimic like this, and sometimes phlegm of carcinoma also can have this kind of cystic areas that also can confuse you for mucodermatoma. Metastatic squamous cell carcinoma with cystic degeneration can also mimic like mucoderma. So we have to be careful when you are interpreting these tumors. Okay, treatment: conservative excision with preservation of the facial nerve is recommended one, and yeah, metastasis is seen in 12% of the cases. The prognosis, overall prognosis is fairly good, even though it is carcinoma. Overall prognosis is fairly okay. Coming to actinic cell carcinoma is another malignancy that is showing a serous acinar differentiation, and it is defined by cytological differentiation towards serous acinar cells, basically. Okay, where the cells will have PS positive zymogen type granules. Okay, and 17% of the primary salivary gland malignancy are actinic cell carcinoma, and 6% of the salivary gland neoplasms are actinic cell. Okay, and coming to clinical features, the middle age, it affects the middle age and female preponderance, and carotid is the most common site, almost 80%. Intraorally, if we take, mostly it involves the lips and buccal mucosa, unlike the other tumors where they involve the palate. Okay, and here it is lips and buccal mucosa. Basically, they are slow growing, mobile, fixed mass, and they have initially they are asymptomatic. Only they become larger and involves the nerve and then the symptom present with some symptoms. Okay, here you can make out the small nodular mass in the hard palate. Okay, here you can see the gray white tumor with some cystic areas where you have the hemorrhage, and sometimes yeah, this kind of solid areas as well as the cystic areas are seen, and sometimes they look very friable. Okay, this is the gross appearance of actinic cell carcinoma. Histologically, if you see, they are basically grade wise, if you see, they are kind of low grade only, but they exhibit infiltrative growth pattern. And even though they are well circumscribed and encapsulated at times, but they can have an infiltrative growth pattern. Mitotic figures are not much seen. Here you can make out all the cells look very benign looking areas, but still like they have the uh, malignant behavior. Okay, so here also you can make out this cytoplasm having this kind of granules, okay, zymogen type granules, and most of the tumor cells are having small nuclei with the abundant cytoplasm. Okay, this is the typical of actinic cell carcinoma. They will almost look like a normal salivary gland. Okay, the differentiation will be like almost like a normal salivary gland. So that's why in FNAC, when you see this type of tumor, you'll be confused with whether they are from the normal salivary gland or it's a tumor. So that time we need to correlate with the radiology and the clinical findings. Okay. And treatment-wise, surgical excision is the same treatment process. And coming to the adenine cystic carcinoma is the one of the more common and best recognized salivary gland malignancies, because there have been a lot of studies in adenine cystic carcinomas, and they are slow growing but aggressive neoplasm. Okay, and they have the marked propensity for the perineural invasion. Okay, adenine cystic carcinoma is a basaloid tumor consisting of epithelial and myoepithelial cells in a variable morphologic configuration, and they including they can come in a tubular form or cribriform, and they can have a solid patterns as well. Okay, clinically 5th to 7th decade, female prognatants, and 50 to 60% involve the minor salivary gland. Palate is the most common, followed by tongue, buccal mucosa. Okay, basically this is a slow growing mass, and yeah. So the patient often can present with a facial nerve paralysis because of the tendency to involve the neural nerves. Okay. Here you can see the tumor here presenting the painful mass in the hard palate. Okay. Maxillary region. Cut section is a solid gray white areas will be seen, and sometimes you may see this kind of hemorrhage areas, and yeah. Histopathologically, they have a composite mixture of myoepithelial cells and ductal cells, and cribriform tubular solid patterns are seen here. So here you can make out this kind of cells in a very tubular format, and here it is more of the tripliform. Here also you can make out the tripliform here, and this is the nerve bundle, and you can see the perineural invasion by the tumor. Okay, that's how they involve. Okay, differential diagnosis comes here: basal cell adenoma, polymorphous low-grade adenocarcinoma, basal and squamous cell carcinoma, basal cell adenocarcinoma. All this comes under the differential diagnosis. Treatment is surgical excision. Overall, the prognosis is poor. Okay. So that's the end of the salivary gland neoplasm. If you have any doubt, you can ask and just read. That's what I always advise. Whenever you listen to any lecture, that day itself you just go and read your textbook so that you will remember it forever. Not only just for up to your exams, but you will remember it for ever. Because once you read the portions, whatever you are learning on that particular day, same day itself you read again, so that it will be like good revision as well as you will not forget actually. So that's why I always advise. Okay. So any clarification, any doubt you have? Alright. Is there anybody speaking? I can't hear any. Okay, thank you. Okay, thank you guys. Hope you guys are safe and doing well and study well. Don't waste your time with the gadgets and utilize the time. And try to read for all the portions, put a timetable and read well. And people are telling that there can be a second wave. So be careful. Don't become very casual with the COVID, and careful and educate your neighbors and your family, other friends as well. Okay. Take care. God bless you all. So I take a leave. Okay. Is it okay? Divya?
Yes, sir. Thank you, sir.
Okay, sure. Thank you.
Thank you.